Hi, and welcome to today's Oxford Centre for Personalised Medicine Flash Interview Series, where we talk to individuals involved in personalised medicine in one way or another. Today, I'm honoured to be speaking to Edoardo Ostinelli, MD Honorary Consultant Psychiatrist and Senior Researcher at the Oxford Precision Psychiatry Lab. Hi, Edoardo. It's great to speak to you today. So would you mind starting off by telling us a bit more about yourself? So who you are, what you do, and your journey so far?
Yes, of course. Many thanks, first of all, Catherine, for the kind introduction and also for inviting me. I'm very, very happy to be here today. So my name is Edoardo Ostinelli. I am a psychiatrist currently based in Oxford, Italian by background, and I started being interested and attracted to research and specifically evidence-based medicine and research methodology while training to become a psychiatrist in Milan, in Italy. I went off for a couple of years in Kyoto, Japan, to learn more about the methods and advanced meta-analytical modeling. And initially, I applied this knowledge focusing on psychosis while being an editor of Cochrane Schizophrenia. But in the last years, I have expanded my interest to depression, mental health in general, and specifically precision medicine applied to psychiatry.
Fantastic. Thanks so much. So if I say personalized medicine, what does that mean to you as a psychiatrist?
So to me, as a psychiatrist, personalized medicine stands for advocating for something better than the traditional one-size-fits-all concept, because at the moment, this concept has been translated clinically into a trial and error approach when you have to choose a treatment. And we know as doctors and patients that this is not enough in medicine, and it's certainly a too simple vision for mental health care. Also, in psychiatry, there is a considerable heterogeneity of treatment effects, and it has been a major challenge for decades. And with precision medicine, we can explore and use this heterogeneity to go beyond the current levels of care and knowledge.
So how do you feel that precision or personalized medicine differs in your field compared to, say, the fields of rare disease or cancer, or the ones that we might initially think about precision medicine?
Well, this is an interesting question. In psychiatry, several potential markers have been proposed, but we're speaking about social demographic variables, biological markers coming from the imaging and genetic fields, but we're still lagging behind other fields of medicine, like cancer, for instance, that you mentioned, in terms of confirming whether these variables are markers of clinical interest, discovering also new markers and translating them into tangible improvements to healthcare. Treatments in psychiatry, mental health, for instance, antidepressants, they have differences. And this is quite clear from the real world experiences of patients and the clinical real world experience of speaking with them. But still, when we look at efficacy data at the population level, it's not uncommon to observe some slight differences and overall comparable performances. And so far, I think that our field, psychiatry, has struggled to capture those incremental differences that at an individual level might differentiate antidepressant performance, both in terms of predictors and outcome. On the other end, our field has a unique combination of characteristics and the potential for improvement. For instance, we can implement more conventional data with what matters to the patient. And just to name a few, this could be patient preferences, subjective PROs, patient-reported outcomes, but also minimally clinical important differences.
So could you tell us a bit more specifically about your work in the precision psychiatry field? So I believe that the OxPPL team developed a tool called PETRUSHKA. Could you tell us a bit more about that?
Yes, PETRUSHKA is an NHR-funded project led by Professor Andrea Cipriani and developed by the OxPPL, the Oxford Precision Psychiatry Lab here in Oxford. And the aim of the PETRUSHKA tool is to match the right antidepressant with the right patient for people experiencing a non-treatment resistant depressive episode, and of course, willing to start the pharmacological medication with antidepressants. So we start only focusing on drugs, pharmacological interventions. And the PETRUSHKA tool currently combines data from 140 randomized controlled trials on depression and observational data from UK primary care. And the aim of the tool is to individually predict how well each antidepressant will perform, the individual likelihood of dropping out from the treatment after 8 weeks, but also the individual likelihood of experiencing 30 common adverse events commonly associated with antidepressant. And together with these individual baseline characteristics, we also elicit the individual preferences on adverse events and combine all this data together to suggest free treatment options. And the idea is that, of course, all of us would like not to prefer experience adverse events at all when taking a medication, but this might be unlikely with currently available treatments, unfortunately. And it might be that due to a number of factors on which we do not have currently data, for instance, the two of us, we might have the same likelihood of experiencing headache and insomnia, but at the same time, with the same intervention, if I had to choose, I might be particularly bothered by headache while you might not tolerate having insomnia at all. And this is the data that we want to capture to support decision-making and foster the conversation between patient and clinician.
So what stage are you at with that tool?
We are currently running a randomized controlled trial on this tool. So the tool has been completely developed, and we are running this trial in United Kingdom and Canada, and it is currently open for recruitment. The tool uses both statistical modeling and machine learning modeling, and we're quite excited about the initial results, and hopefully we will be able to share updates soon by the end of the year.
Brilliant. Fingers crossed then for good results in the future. Finally, looking forward then, where would you like to see the field of personalised medicine in psychiatry heading in the next decade or so? And what do you think will be the biggest challenges and hurdles, and how might we overcome these?
Well, in the future, I think that personalized medicine in psychiatry, applied to psychiatry, will have to optimize the data that we are starting to collect. I'm thinking, for instance, of genetic and imaging data, and understand how to better implement and combine this data with clinical tabular and non-tabular data. When I say non-tabular, I'm thinking, for instance, about NLP, natural language processing, for instance, directly from the clinical notes, and also taking into consideration also the individual preferences of the patients. And I think that this will be instrumental both for the traditional precision psychiatry that aims to develop new medications or new treatments, but also the so-called pragmatic precision psychiatry, which is, if you want, closer to the PETRUSHKA tool right now, that is to link and to match the right treatment to the right participant, potentially also at the right time.
Brilliant. Thank you so much for your time today. Have you got anything else that you want to add before we finish?
No, just many thanks. And if anybody is interested into what we do at the Oxford Precision Psychiatry Lab, please get in touch.
Great. Thank you very much.
Thank you very much.